Chronic kidney disease, or CKD, is defined as abnormalities in kidney function or structure for greater than 3 months that impacts health. Over 25 million people in the US are affected by CKD. The most common causes of CKD are uncontrolled hypertension and diabetes, which together account for 2/3 of the cases of CKD seen every year. Diabetes is a condition characterized by chronic high blood sugar and can impair the kidney through mechanisms such as hyperfiltration, advanced glycation products, and the activation of cytokines. While appropriate management of hypertension and diabetes can slow CKD progression, reversal is not possible and the disease will continue to progress over the patient's lifetime.
There were over 600,000 cases of end-stage renal disease, or ESRD, in 2013. Currently, there are 2 treatment options available for patients with ESRD, dialysis or transplantation. In 2013, over 17,000 kidney transplants were performed in the US, despite a waiting list exceeding 100,000 patients. Furthermore, the average cost of hemodialysis per patient per year was estimated at $89,000. Individuals who received a transplant had an average cost of surgery of $34,000, and post-surgical costs, which include lifelong immunosuppressive therapy, have been estimated at $25,000 annually. The shortage of donor kidneys and the numerous associated costs of ESRD reflect the high demand for more effective treatment options that can delay the progression of renal dysfunction.
Vitamin D is a common product found in prescription and over-the-counter formulations. Accumulating evidence has found an inverse relationship between circulating activated vitamin D and activity in the renin-angiotensin-aldosterone system, or RAS. The mainstay of treatment for diabetes and hypertension is use of an ACE inhibitor, which also blocks the RAS system. Based on the similarity in activity to current renoprotective medications, vitamin D may be considered a potential agent to augment RAS blockade and further slow kidney damage.
Our proposed project is a retrospective observational study using data from the Veterans Health Administration, or VHA, studying the effect and cost-effectiveness of vitamin D on renal outcomes in diabetes and CKD. According to the VHA, nearly 1 in 4 veterans receiving care from the VA has diabetes, which makes CKD an imminent threat to this population. Because our proposed study is retrospective and observational in nature, without incorporating appropriate statistical methods to account for unobserved variables, the findings of our study may be severely limited due to selection bias. One statistical method that reduces the risk of this is the use of an instrumental variable, which is a selected factor that influences the selection into treatment but is unrelated to the outcome of interest. Research has suggested that vitamin D analogs can be beneficial in the treatment of prostate cancer due to their anti-proliferative effects on cancer cells. Because prescribers may use vitamin D on prostate cancer without regards to its renal effects, we anticipate that vitamin D prescribing patterns in prostate cancer as an instrumental variable will appropriately account for unobserved variables in our study cohort and thereby reduce possible confounding in the results.
Our study focuses on the following aims. Aim 1. Determine the prevalence of vitamin D use in patients with prostate cancer, diabetes, and CKD. Using data from the VHA Medical SAS and DSS, we will obtain a cohort of patients who have concomitant diabetes, CKD, and prostate cancer through identification of ICD-9-CM codes and GFR lab values. We hypothesize that prostate cancer diagnosis will be associated with vitamin D use, suggesting that providers are aware of and are using vitamin D in prostate cancer. Aim 2. To investigate the benefits of vitamin D in patients with diabetes and CKD. As mentioned earlier, we plan to use prostate cancer vitamin D prescribing as an instrumental variable to determine the agent's effects on renal outcomes. We hypothesize that the receipt of vitamin D in those with diabetes, CKD, and prostate cancer results in a slowed decline in renal function compared to those patients not receiving vitamin D in the study population. Aim 3. Explore the cost-effectiveness associated with slowing the further progression of CKD. In this third aim, we will gather cost and utilization data through the use of ICD-9-CM codes, CPT procedure codes, prescription data, and lab test utilization. Building upon Aim 2, we hypothesize in this aim that the cost of treatment per month will be lower in the vitamin D group due to its protective effects on renal function, thereby reducing the need for costly therapies and procedures.
From the data collected and reported by the U.S. Renal Data System and other agencies, it is evident that costs associated with end-stage renal disease are significant for patient, insurance company, and government alike.
Additionally, the disequilibrium between the supply of donor kidneys and the demand for new organs means that many patients may expire while waiting for life-saving surgery.
Considering the widespread availability of vitamin D as well as its low cost, it would make a relatively benign add-on therapy to patients with diabetes and some form of nephropathy, and thus we believe that its use in this patient population is worth exploring.